Good afternoon, everybody. Good afternoon, Mauricio.
Good afternoon.
We are here to run a session concerning the non-mainstream aspects of psychiatry with Professor Mauricio Tohen from New Mexico, US. Mauricio, you have a few words to say?
Well, it's a pleasure for me to be here today, and we will contribute to the conference with our point of view here from New Mexico. It's a pleasure to be here, Professor Fontanacolis.
Costas is much easier.
Okay.
We will start first with a speech by Dr. Kumati, who belongs to my research group, and will talk about a very, very delicate, very difficult, and very foggy issue, that of the attenuated psychosis.
Good evening, everyone. First of all, I would like to thank Professor Fontoullakis for inviting me here today, as well as Professor Tohen. It is a great honor for me to have this opportunity. The subject of my presentation is attenuated psychosis and conspiracism. Additionally, I am going to briefly present you our study, the topic of which is the attenuated psychosis syndrome. Attenuated psychosis syndrome is one of the more complex mental illnesses that baffles psychiatrists to this day. It is a mental condition that causes clinically significant distress and is distinguished by the onset of mild, psychosis-like symptoms. Attenuated means weakened, and this is why this disorder is called attenuated psychosis syndrome. DSM-5 included attenuated psychosis syndrome in Section 3 under conditions for further study. The DSM-5 task force determined that there was insufficient evidence to warrant inclusion of APS as official mental disorder diagnosis in Section 2. These proposed criteria sets are not intended for clinical use. You can see these criteria on the table. Attenuated psychotic symptoms, as defined in criterion A, are psychosis-like, but below the threshold for a full psychotic disorder. Compared with psychotic disorders, the symptoms are less severe and more transient, and insight is relatively maintained. The psychopathology has not progressed to a full psychotic severity. Attenuated psychosis syndrome is a disorder based on the manifest pathology and impaired function and distress. Changes in experiences and behaviors are noted by the individual or others, suggesting a change in mental state. A delusion is defined as a false belief, an unshakable belief, held with extraordinary conviction and with subjective certainty. The decision to call a belief delusional is not made by the person holding the belief, but by an external observer. Attenuated delusions may have suspiciousness or persecutory ideational content, including persecutory ideas of reference. The individual may have a guarded, distrustful attitude. When the delusions are moderate in severity, the individual views others as untrustworthy. And when the delusions are severe, but still within the attenuated range, the individual entertains loosely organized beliefs about danger or hostile intention, but the delusions do not have the fixed nature that is necessary for the diagnosis of a psychotic disorder. Attenuated delusions may have a grandiose content, presenting as unrealistic sense of superior capacity, and that could even be dangerous for the individual. Thoughts of being special may lead to unrealistic plans and investments. The attenuated hallucinations include alterations in sensory perception, usually auditory or visual. When the hallucinations are moderate, the sounds and images are often unformed, for example, shadows, trails, halos, murmurs, or rumbling. And when the hallucinations are severe, these experiences become more frequent and more vivid. The perceptual abnormalities may disrupt behavior, but skepticism about the reality can still be induced. Disorganized communication may manifest as odd speech, for example, vague, metaphorical, over-elaborate, or stereotyped speech, as unfocused speech, for instance, confused, muddled, too fast or too slow, wrong words, irrelevant, or as meandering speech, for example, circumstantial or tangential. When the disorganization is moderately severe, the individual frequently gets into irrelevant topics but responds easily to clarifying questions. Speech may be odd but is still understandable. But at the severe level, some thought blocking or loose associations may occur infrequently, especially when the person is under pressure. The individual realizes that changes in mental state or in relationships are taking place, and the person maintains reasonable insight. The individual must experience distress or impaired performance in social or role functioning, and the individual or responsible others must note the changes and express concern, such that clinical care is sought. Some features that support the diagnosis include magical thinking, perceptual aberrations, difficulty in concentration, disorganization in thought or in behavior, excessive suspiciousness, anxiety, social withdrawal, disruption in sleep-wake cycle, impaired cognitive function, and some negative symptoms. Neuroimaging data is not diagnostic at the individual level. The prevalence of attenuated psychosis syndrome is still unknown. Symptoms in criterion A, hallucinations, delusions, and disorganized speech, are not uncommon in the non-help-seeking population, ranging from 8% to 13% for hallucinatory experiences and delusional thinking. This appears to be a slight male preponderance for APS. Onset of APS is usually in adolescence or early adulthood. It may be preceded by normal development or evidence for impaired cognition, negative symptoms, or impaired social development. In some cases, the syndrome may transition to a depressive or to a bipolar disorder with psychotic features, but development to schizophrenia is more frequent. Factors predicting prognosis of APS have not been definitely characterized, but the presence of negative symptoms, cognitive impairments, and poor functioning are associated with poor outcome and increased risk for transition to psychosis. A family history of psychosis places the individual with APS at increased risk for developing a full psychotic disorder. Structural, functional, and neurochemical imaging data are also associated with increased risk of transition to psychosis. Many individuals may experience functional impairments. Modest to moderate impairment in social or role functioning may persist even with abatement of the symptoms. A substantial portion of individuals with a diagnosis will improve over time. Many of them continue to have mild symptoms, and many of them will have a full recovery. The attention study is an international study concerning the presence of attenuated psychosis in the general population. The data are gathered online. Our target group is the general population and is self-selected. The tools we used include a socio-demographic protocol, a protocol registering known mental health issues, a scale-like list of items pertaining to attenuated psychotic symptoms, and some scales registering depression, anxiety, and suicidality. The initial original questionnaire was in English. We promoted this questionnaire to foreign colleagues all over the world in order for them to translate it. We are currently receiving the separate translations, and we are creating the multiple translations in Google Forms so that the different questionnaires are similar to each other. Here, you can see some of the translations we have already received. Here you can see the Croatian version. Here the Malaysian one. And here is the Japanese version, my personal favorite. And some questions, as you can see here. And now I'm going to share with you some results. On this slide, taking the answers into consideration, we conclude that the certain pathological traits are at a moderate level. Let me show you the first pie chart. To the question, have other people told you that you speak incoherently? As you can see, only 1% of the participants answered often or all the time, whereas the majority answered never. And almost 60% of them answered rarely. To the question, do you feel that your body or parts of it change shape? The majority answered never, and almost 9% of the people answered sometimes. 2.4% of them answered often or all the time. Regarding to the question, do you feel a lack of ability to enjoy activities you normally enjoy? The higher percentage of the participants replied rarely, and a large part of them replied never. This question concerns anhedonia, a negative symptom of APS. And this slide depicts which pathological traits are rather usual. For instance, let's have a look at this pie chart. Do you feel that ideas or thoughts are being broadcast out of your head? To this question, almost 18% of the participants answered often or all the time, and almost 34% of them answered sometimes. Almost 30% answered never. This percentage is considered to be high. And this graph depicts the answers to the question, do you feel detached or away from the surroundings, as if you are playing in some kind of a theater, as if nothing really touches you? As you can see, almost 6% of the people answered often or all the time, and almost 24% of them answered sometimes. Regarding to the question, do you feel as if you were not yourself, as if you were some kind of a robot? This graph shows that the larger portion of the participants answered never. On the other hand, almost 8% of them answered sometimes, and only 1% of them answered often or all the time. And the following pie charts depict quasi-pathological traits that seem to be rather unusual. To the question, do you believe that there is a political conspiracy against you? Only 1% of the participants answered much or very much, and the majority of them answered not at all. Regarding to the question, do you ever feel persecuted? If you take a look at this graph, you will notice that only 0.3% of the participants answered often or all the time. The majority answered never, and almost 9% of them answered rarely. And the last pie chart shows the answers to the question, do you feel there is some kind of a love affair between yourself and a famous person concerning erotomania? Only a small minority of the participants, and particularly 0.1% of them, answered often or all the time, whereas almost 96% of them replied never. It must be noted that according to some anchor questions, the real rates of the pathological traits are almost the half of those noticed in the research. Our result might be biased, and the symptoms are self-reported, reflecting the individual's internal experiences, thoughts, and emotions rather than the individual's behavior that can be observed by the others. To conclude, I would like to thank you for your attention. And if you have any questions, please do not hesitate to ask.
Thank you, Dr. Koumati. Are there any questions? The presentation was very detailed and comprehensive, I think, and some of the results, these are initial results from Greece, suggesting that a significant percentage of the population might have some kind of quasi-attenuated, quasi-psychotic symptoms. And what is very interesting, I don't know if you agree, Mauricio, the thought broadcasting was excessively high in comparison to other, for example, persecutory thinking, which might mean that they perceive the question in a different way than we think. That could be an explanation. Otherwise, I don't know what.
If I can add a comment, I was part of the DSM-5 field trials that studied this condition, and we were recruiting patients out of a clinical setting. A psychiatric clinical setting. And it was difficult to recruit patients. The reason is because many of these individuals do not seek care, or if they seek care, it's going to be with a primary care provider. And also they are first noticed when they come in contact, say, with the police, because they behave in an erratic way, or they committed some small crime like trespassing. I think what's important is to identify this condition, and we need to do a lot of public education. We need to educate teachers. We need to educate law enforcement. we need to educate the public about the existence of this condition. And to the question, why is it important to identify this condition? Well, in some cases, it will just evolve and the individual can function quite highly. And this is actually also an interesting factor. For instance, here in New Mexico, we have a diverse population, and that it includes those from European descent, the Hispanics, and the Native American population. And within the Native American populations, there are beliefs that this population has that for us who come from a Western perspective might appear abnormal, but in their beliefs, it is not. So I think we should, the cultural issue is very, very important. And I applaud you, Kostas, and your team for making this a global project, because it will enable us to identify cultural or regional issues, or those related to religious beliefs. One more comment that I would like to make is that the importance of identifying this condition is that in some cases, and we don't have the data in terms of how many cases, it can evolve to a first episode of psychosis. And we all know that a factor that will affect outcome in first episode psychosis is the duration of untreated psychosis. So that is why it's so important to identify cases that move from attenuated psychosis. Another term that is now being used in the US is clinical high risk of psychosis. So they're at high risk. So if we can identify those individuals who are at risk of developing a first episode psychosis, and then make sure that they receive treatment on time, because the longer it takes to initiate, in this case, antipsychotic treatment, that affects the long-term outcome. So it is a very interesting area of psychiatry that includes preventive medicine, and it includes, of course, cultural factors that vary from place to place. I'm very honored to be in this presentation, and again, I applaud your efforts, Professor Kostas. And this, Dr. Manny, this was a very, very good presentation. It was detailed, and it actually focused on areas that matter. Back to you, Dr. Kostas.
We will see how the international data will go. It's, you know, some of these questions, some of these items are culturally sensitive, and we don't know how they will perform, especially online. But we will see. Thank you very much for your presentation. We will continue with the second speech by Dr. Mitkani, who is a resident in neurology, and will discuss the issue of vascular depression.
Good evening, everybody. I would like to thank Mr. Fountoulakis for this invitation in this special conference. Our topic is vascular depression. In the current presentation, we're going to talk about late life depression. We're going to show you some results of our study. We're going to talk about vascular depression hypothesis, its clinical features, some possible etiopathogenesis, the structural brain abnormalities, and perspectives on patients' management and treatment. Major depressive disorder is a common illness worldwide, and 3.8% of the population is affected, 5% among adults and 5.7% among adults older than 60 years of age, according to the World Health Organization for 2021. Subsyndromal depression is commonly dwelling older adults, and it's about 12 to 30%, while major depressive disorder is 2 to 5% according to the DSM-4 text-revised criteria. In the elderly, there is usually a lower risk of a depressive episode. There are worse consequences and prognosis of depression, an unfavorable clinical course, higher relapse rates, a worse treatment response, and finally, incomplete functional recovery. Late life depression is commonly defined as any depressive episode occurring at age 65 or later in life, regardless of the age of onset. Late onset depression is when the first lifetime depressive episode begins after the age of 65. And here we have some newer studies that place this cutoff point at 50 or 60 years of age. And early onset depression, which is when an older adult has experienced recurrent depressive episodes with the first episode occurring earlier in life. The clinical significance and complex basis may affect the outcome and also increase the risk of cognitive impairment and poor quality of life. Late life depression is also associated with cerebrovascular comorbidities and special brain lesions. In our study that took place in HEPA University Hospital with Mr. Foundoulakis, Mr. Tegos, and Mr. Kimiskidis, there were 21 patients, 13 of them were females, with a first acute ischemic stroke, a lacunar stroke due to small vessel disease, and the mean age of our patients was 60 years. All patients underwent a brain MRI, and patients with atrial fibrillation, severe carotid stenosis, or any other thromboembolic source were excluded. All patients were evaluated by direct interview, and a complete medical and psychiatric record was obtained. Information was also obtained from a relative or a carer. The rest, more common comorbidities for these patients were hypertension, dyslipidemia, and type 2 diabetes with no difference between sexes. And about our results. 47.61%, 10 of 21 patients, most of them females, experienced symptoms of mild to severe depressive disorder with a mean of 7 years before the onset of the first ischemic stroke. All of them were receiving treatment with antidepressants and benzodiazepines. The mean age of onset of depression was 53 years, and there was no history of manic, mixed, or hypomanic episodes. There was also no difference in age between patients with history of depression before stroke and those without. There was a tendency for patients with history of depression to have higher paternal age at delivery, but not maternal. The conclusions of our study was that there is a positive relationship between late onset depression and small vessel disease, followed by a stroke several years after the onset of depression. That female sex might constitute a particular risk factor, and about the tendency concerning paternal age at delivery that deserves further study. In this picture, we can see a brain MRI, a T2 FLAIR image of a 60-year-old male patient, the only male patient that we had with depression beginning 10 years before the lacunar stroke. There are several other studies showing a positive correlation between cerebral small vessel disease and depression, and this correlation is so strong that there is a nosological entity called vascular depression. The vascular depression hypothesis was suggested in 1997 by Alexopoulos and his partners, and argues that cerebrovascular disease, including small vessel ischemic changes, may predispose, precipitate, or perpetuate some geriatric depressive symptoms as a consequence of structural damage to frontal subcortical circuits with the disruption of corticostriatopallidothalamocortical pathways as their underlying systems. The vascular depression hypothesis is also supported by newer MRI-based studies, which argue that vascular depression accounts for up to 50% of major depressive disorder cases in the elderly. Its clinical features, the most important ones, are that it is a depression occurring at age 60 to 65 years or later, and from newer studies after 50 years, that there is an absence of family history, there is higher cardiac illness burden and increased rates of cardiovascular risk factors, with hypertension, diabetes, and hypercholesterolemia to be the most important ones. There are special neuroimaging findings, especially white matter hyperintensities, and that there is a higher risk for cognitive decline and progression to cognitive impairment and final dementia. There is also greater treatment resistance and poorer outcomes. What's the possibility of pathogenesis? We have the known cardiovascular risk factors, as we said before, including smoking, homocystinemia, and the most important ones, hypertension, that cause vascular inflammation and cerebral small vessel disease. And with the endothelial dysfunction, we have the blood-brain barrier damage, and this has a result to reduce the cerebral blood flow, and we have white and gray matter lesions. These lesions, in combination with some stress and adverse life events, push social support from family, and we have vascular depression. The structural brain abnormalities we see in vascular depression, the most important ones, are white matter hyperintensities that we can see on T2-weighted structural MRI images, and they are located especially periventricular. These lesions are not restricted to pathologic conditions, and they are a common phenomenon in aging. But we saw that more frequently they were found in individuals with late-life depression compared to AIDS-matched controls, and that the greatest burden of white matter hyperintensities is associated with a great dysfunction in motor, cognitive, and emotional circuits. The association between the hyperintensities and depression seems to be strongly dependent on age at illness onset. The white matter changes on MRI independently are of little clinical value to predict depressive symptoms. But when they're viewed as a part of an entire clinical presentation, there is suspicion for further depressive symptoms. The greater the severity of these MRI hyperintensities is, the poorer the response to antidepressants, an increased relapse rate, and a more chronic course of depression. Here you can also see an MRI from a female 74-year-old patient with a late-onset depression and 8 years before her first stroke. The rest structural brain abnormalities we can see are subcortical lacunes, microinfarcts and microbleeds, enlarged perivascular spaces, frontal and temporal gray matter changes and atrophy, neurodegenerative pathologies, related biochemical changes, and impaired structural connectivity. There are some PET studies that have demonstrated an increase in cortical glucose metabolism, and also amyloid PET studies that showed increased alpha-beta deposition in frontal, parietal, temporal, and occipital cortex. Vascular depression is often characterized as a disorder of executive dysfunction, and this is because these elderly people have a special difficulty with task completion and with decision making, and this leads to increased likelihood of irritability and social withdrawal. In the elderly, even subthreshold depressive disorders can have a substantial impact on functional status, quality of life, and finally mortality. The assessment for vascular depression ideally includes a full review of vascular risk factors, a history of vascular disease, and evidence demonstrating subcortical white matter disease. We can understand that it's difficult for clinical radiologists to raise clinical concerns unless the white matter changes are particularly severe or there is a clinical background that describes cognitive changes and motor impairment. So the burden may fall on the psychiatrist to bring together the imaging information with the clinical features of a possible vascular depression. Some evidence-based therapies include antidepressants, with SSRIs and SNRIs to be promising options, electroconvulsive therapy, transcranial magnetic stimulation, and specific psychotherapies. The response to treatment is often significantly attenuated in vascular depression, so the typical treatment strategies are often unsatisfactory. There is a poor response to depressants and a persistence of the depressive symptoms, and this can contribute to a poor self-management of the other medical comorbidities. From some studies, we have seen that citalopram and methylphenidate has demonstrated a higher rate of remission compared with either drug alone and also improves functioning. Also, the accommodation of antidepressants with either lithium or aripiprazole was somewhat effective in these patients who were unresponsive to other antidepressants. In the depressed elderly patients that have also cognitive impairment, a combination of antidepressants and donepezil had temporary positive effects on cognitive function, but there was a risk of recurrence. So we have to keep in mind that antidepressants in the elderly should be initiated at a low dose and increased gradually with exercise and caution as to the possible adverse reactions. Electroconvulsive therapy seems to be the most efficacious treatment for vascular depression, with remission rates of 60 to 80%. But there are different notions about the impact of the vascular risk factors to these therapies. Deep transcranial magnetic stimulation was also reported to be beneficial. What is really important is the treatment of vascular risk factors, especially hypertension, so that cerebral autoregulation can be improved and the cerebral blood flow to be increased. There are some preventive methods that may also favorably influence the risk of cardiovascular disease and depression, and this is the treatment of hypercholesterolemia, hyperglycemia, obesity, smoking, nutrition, lifestyle modification, and a better stress management. We have to keep in mind that comorbid medical disorders must be considered when planning the treatment of vascular depression. Neuroinflammation may be a key therapeutic target for future strategies, and as we have seen, NSAIDs and cytokine antagonists to have antidepressant properties in some patients. And psychotherapies that target behavioral domains need still to be validated as it concerns their effectiveness. To conclude, to date, the concept of vascular depression is not widely accepted. There are no formally agreed definitions, no diagnostic criteria, the pathomechanisms are not fully understood, the natural history is unknown, and no specific therapy has been confirmed. What we know is that it shows a less favorable response to antidepressive therapy than major depressive disorder in a younger age. So from the therapeutic aspect, early recognition and treatment of all these risk factors is important, using accepted guidelines for the diagnosis and treatment of hypertension, diabetes, and cardiovascular and cerebrovascular diseases, as well as an early screening for late-life depression using adequate depression questionnaires. A depression diagnosis that differentiates vascular from non-vascular depression might allow for a more individualized treatment plan. Thank you for your attention.
Thank you for your very detailed and in-depth presentation. Are there any questions? I don't see any questions in the chat. Are there any questions from the audience? This is a very delicate, very important thing because most vascular patients are treated by neurologists. And I'm not happy to say that many colleagues have a dualistic aspect, a dualistic view of brain and mental disorders and neurological disorders, and they tend to believe that depression in vascular patients is some kind of reactive depression, some kind of a coping mechanism, some kind of sadness. On the contrary, it seems to be an early warning sign that a vascular disease is in progress, and maybe some 7 to 10 years later, we will have a major stroke. And also, the treatment of vascular factors could alleviate depression, or at least it could enhance antidepressant treatment. But if left untreated, then things will only worsen. Often, we treat patients in our clinical practice that we treat them in a fragmented way. We tend to treat only their mental status, and the neurologists tend to treat only their neurological status, where the brain is one and it's a single organ. So it needs a comprehensive and multidimensional treatment of all factors in order to achieve the optimum treatment result. So this presentation suggests that organic factors could contribute or even 100% cause a pure mental disorder with all the characteristics of a mental disorder, because geriatric depression, sometimes it is reported to differ in terms of symptomatology from early onset depression, but this is very weak. As an observation, it's statistical difference, but it's not a clinical difference. It's not something that you can tell in your everyday clinical practice. You cannot tell that, okay, this is organic depression. It's depression, and you need to check whether there are vascular risk factors underneath, and you need to treat them. Insufficient blood supply could lead not only to depression, but also to reversible dementia. And if you correct the insufficiency of blood supply, then you might reverse dementia-like deficits. So this is the essence of this presentation. Are there any comments? If not, we will conclude this session. Thank you, everybody, for being here. We have 7 minutes to the next session. Thank you.